is Santosh Sinha, and currently I'm responsible for the entire West zone of micro labs for the carcinogen division. I welcome you for this live webinar. Thanks to all our doctors who have given your time for this webinar. We are fortunate to have the few renowned doctors of the world fame of Asia fame, Dr. Sunil Sathi from Pune and Dr. Himraj Chandalia from Mumbai. Today's talk about the latest sprint trial. So let me also introduce all of you to Dr. Sanjana. Dr. Sanjana is MBBS from the Vaidehi Institute of Bangalore, and she's also done MD in the pharmacology from Rajarajeshwari Medical College, that is in Bangalore. So Dr. Sanjana represents medical affiliate team in the Micro Labs Limited. Now I request Dr. Sanjana to take towards the scientific session. Thank you, Dr. Sanjana.
Thank you, Santosh. Good evening, everybody. Thank you for taking your time and attending today's webinar, which is on the latest update on hypertension and what is new. So hypertension is highly prevalent in our adult population, among whom isolated systolic hypertension is the most common form of hypertension. So systolic blood pressure becomes the most important and an independent risk factor for coronary events, stroke, heart failure, and end-stage renal disease. The SPRINT trial was based on the fact that people without diabetes, the targets of systolic blood pressure were unknown or uncertain. So to talk more about this, we have Dr. Sunil Sathi. Sir is the consultant cardiologist at Cardiac Care and Counseling Center, and Sir is also the visiting associate cardiology at Australia. Sir has completed his MD in medicine and DNB in medicine, DM cardiology and DNB in cardiology. Sir has also done training in interventional cardiology and electrophysiology at Royal Melbourne Hospital, Australia. Sir has several national and international publications, and his special interest is in interventional cardiology and electrophysiology. I would like to request Dr. Sunil Sathi to introduce our speaker for today's program.
Yeah, thank you, Dr. Sanjana. I think it's my proud privilege to introduce Dr. Himraj Chandalia. I think he's too famous to be introduced, honestly. And interestingly, I must tell you that in 1985-86, I was a cardiology resident at the Jaslok. And even during that time, if there was anything to do with endocrinology or diabetology, especially, we knew only one name, and that was Dr. Chandalia. That was way back in 1986. Of course, today he's the director of Denmark and the professor of endocrinology and diabetes. In fact, the most important three aspects I would like to tell about him is that he has been a great teacher. He is still a great teacher, and he has taught thousands of students right from those days at the Grand Medical College and the Jaslok Hospital. He is a prolific writer, and that's extremely important, and of course, a great orator. So it's my proud privilege to introduce Dr. Chandalia, and I would now request Dr. Chandalia to go ahead with his talk on the newer aspects of the SPRINT trial. Dr. Chandalia, please.
Thank you. Thank you, Dr. Sathi, and thanks to Micro for bringing us together to discuss this very, very important aspect of our clinical practice, and that is hypertension. And of course, what kind of goals we should achieve while controlling hypertension? What should be our trigger point where we initiate pharmacological therapy? These are perennial controversial subjects, and there is volume of literature on that. I'll touch upon some of that with specific focus on SPRINT trial. So hypertension, of course, is highly prevalent, so I will not lose much time on some of these very well-known aspects, you see. And remember that, very interestingly, any blood pressure above 120/80, it means even 130, 135, 140 systolic, also is likely to increase the cardiac events. So this is very important. So this is how the concept rose that we should have a goal which reaches this 120/80, because you've seen that the risk rises. Of course, it rises far more when you go further, but remember that adding, you see, in systolic pressure, and in diastolic pressure only by a small number like 10 or 15, see, and can increase multiply the double risk by double. So every stage it progresses, the risk progresses. So you can see that very high blood pressure is imminently danger, really, in fact, a very grave risk factor. In fact, when we treat our people, including diabetics, we are more worried about a poorly controlled blood pressure than diabetes, because it has it's a much faster impact on the cardiovascular system than what a poor glycemic control will do. So very, very important to tackle this. World over, the incidence is very high. You see, India is somewhere in the middle range. The blue color here is 30% or so. So these are some of the epidemiological data on the basis of which you see here high prevalence of this disease. So if you see this is the prevalence, then you can see how important this subject is. So next slide, it shows in India now, this is Indian data, and they show that most part is green, so the incidence is low there. You know, in women, of course, overall less, in men, little more. And of course, we see here in men, Haryana and Punjab probably is maximum, you know, incidence is very high. So it goes to about 20-25%. So I think highly prevalent disease. Now, classifying hypertension really is based upon the degree of hypertension, really, you see. Besides, of course, we know we are talking today of essential hypertension. We are not talking of any causes, any secondary kind of hypertension for which the clinical approach is tackling the basic problem, causation. So here we are dealing only with that. And this can be very arbitrary, but all societies sometimes fix for the purposes of the uniform reporting of data. And whenever you launch any study, you know it's better that you have a classification which is well accepted, at least in the country in which you are working. So therefore, you have some of these gradations, frankly, grade 1, grade 2, grade 3. It really means more and more severe hypertension as you go up, you see, on systolic and of course in the diastolic as well. See, next slide. So I think this classification is very arbitrary for the sake of convenience of reporting and collating data. Now, you see, what should trigger treatment is a very important thing. So you detect, for example, a blood pressure of 135 or 130 systolic in a young man at the age of 25 or 30. See, and essential hypertension does start somewhere at 35, 40. It doesn't start at a late age, mind you, and then slowly progresses as the life goes on. See, so remember that what stage should you institute treatment? And of course, I think the lifestyle intervention will start even at 130 or 135 systolic. It should start, because we saw that anything above 120 is injurious to cardiovascular system. Now here you see, frankly, the table is a very simple one, because in all stages, really the trigger point is more than 140 systolic and 190 diastolic. So frankly, you can say the whole table, the summary is very simple. Only you see that people who are elderly, like above 160, above 80 years age, there, you know, you have trigger point a little high. The reason for this is not because blood pressure can be high in elderly people. This was a very old concept 50 years ago. That is absolutely wrong. Now, the only thing is measuring blood pressure in an elderly with arterioles getting stiff gets the false little high value. So intra-arterial pressure we still want not above 140, remember. But it is really little false readings that you get because of the stiff arteries, you know, and therefore, although the intravascular pressure, if you take, I think the level will be again similar. If the desired level at the trigger at which you will start acting will be same. So frankly, it is about 140 that you start working, and 90 is a trigger point where you must think of treating the patient. Obviously, it's a little bit of lifestyle intervention, but drug therapy has a tremendous role here, because salt restriction, of course, can be reasonably effective, but any severe hypertension, it does not take you to the target. So you have to really have, you see, the drug therapy introduced. We are not discussing the drugs today. What we are discussing is what kind of goal, where should you start the treatment and what is your goal? Now, what should be the goal? That has been a very, very highly debated issue all along, because some people like me have witnessed this debate for 50 years. So the very early studies like VA cooperative study, and there was hypertension optimum control called HOT trial, all those, you know, initiated, they show that control of hypertension is very crucial to the cardiovascular protection. So these were the early studies. We drew our attention to that. And then we started slowing, narrowing down to the fact that what level should we achieve? And that is what we'll be discussing in the rest of the time today at my disposal. So I think it is again classification. I would not worry about that, the gradation. They are really not very scientific. These are arbitrary, made by all associations so that we can work together. Now, you see, so targets are what our discussion today is centering around sprint, but we will take I will make some general statements. Very important to put it in a perspective, and of course some discussion which will follow, where I think Dr. Sathe should participate more because he's a cardiologist and it is his forte as well. So and more than mine, of course, I treat a lot of hypertension, but it is a primary subject. So I think we'll take that issue there. But sprint trial is our focus today. And why it became focus, it was really reported in 2015, basic report. But afterwards, there was some follow-up also after termination of the trial. There was a sort of observational study follow-up that went on for about half a year. But somehow or other, the data really got into the NEJM just last month or so in 2021. So this is how it does become again a little hot topic, sprint trial. See, and this trial was primarily focused on finding out what should be what is the most desirable, most optimum blood pressure goal. So the American College of Cardiology, American Heart Association, 130/80. Remember, when we talk about blood pressure readings, I must warn you, this is very important and basic though, that a reading taken simply in the office very quickly when the patient enters your clinic, you see, without even allowing him to breathe, and rest, for 2 or 3 minutes or 5 minutes, and not in a quiet room, that reading is always a little bit higher. It is 5 to 15 milligram higher than a real proper office reading or properly taken oscillometric blood pressure instrument reading. So this is very important to know. See, because there is white coat hypertension and it adds about 5 to 15 milligram. The sprint trial was conducted, you see, in the blood pressure were measured by automated oscillatory BP instruments. Automated was. Without the presence, a person will be out of room and the patient will be quietly in one room and of course rested for some 5-10 minutes and very comfortably sitting in a chair, you see, and then measure. So I think we have to be very careful. If we see conclusions of sprint that optimum is 120/80, remember that translating into clinical practice, it will be still 130/80, 130/80 or 85. You see, because that difference is there in measurements and we should be very acutely conscious of this. And of course, if we improve our way of measure blood pressure, it will help a lot there. You see, if we measure properly, then probably we will get closer to the study goals that then we can go to the closer to the study goals. You see, however, in these matter, as well as I keep discussing glycemic goals for on the diabetes platforms. And mind you, ultimately the key, I will tell you in the end also, the essence is really individualization. We discuss a lot of studies. The studies give you some guideline that how do you individualize? It gives you key to that. But ultimately the individualization, because given patient, you see, you will try to achieve these goals without producing any problem. It should be tolerable to the patient. Side effects should not be very bad, especially hypotension, hypoperfusion, sometimes organ systems, fainting, syncope, all those are possible. And therefore, I think you are limited by that. And this holds true in clinical medicine all over, that you try to achieve your goals, of course, without primarily producing no harm. What we call the primary way we practice is primum non nocere, we say primary do no harm to the patient. So I think this would be ultimately how we all translate it to practice. Yet we need studies like this to give us some guide as to where we are trying to go. Whether we go there or not will matter in an individual patient. So anyway, so targets for treated hypertension, you see here the ACC and AHA guidelines and European Society of Cardiology. And of course, there are some Indian guidelines, Indian Society of Hypertension as well. And they are really similar. You see, Some of them, nighttime and daytime will be different. So this is most of the time we are talking about daytime data. These studies are conducted in daytime, but of course, you know extremely well what the nocturnal variation. And there, I think it will be was 10 or 5 systolic, diastolic less as a target in the nocturnal blood pressure. See, and all the same, too much dipping of nocturnal blood pressure can produce some ischemic events. You see, so that also. So both way, you are really steering your course between the devil and deep sea, and you have to really become very, very efficient to do that. See, next slide. So please go on quickly. Yeah. Okay. So this is the office systolic blood pressure measurement, but these are proper ones. And again, you see targets are similar. You see most of the time. Now, does presence of diabetes, CKD, coronary artery disease, and previous stroke alter your goals? On that, there are many studies on each aspect of that. You see, and I'll quote some of those for you. You see, for example, let us say the studies as far as elderly is concerned now. Elderly, also you try to achieve same strict targets. Yes, but you can get a lot of trouble. And of course, there are some papers from Japan. I see a very massive paper and a meta-analysis showing, and there are a lot of elderly people they treat that lowering below 140 systolic is not very, very productive in the elderly people. So you will find differencing opinion in some very good papers. In diabetes, should you lower to the same? Here in this table, more or less the targets are same. So you would try to achieve, but however, you'll modify it based upon the knowledge that you have or the studies that you see. An ACCORD study where the hypertension was very strictly controlled, see, and the very strict control group, the tight control group, you see, it did not really benefit much in cardiovascular event. I must tell you that glycemic also tight control produced problems there. But it reduced little bit it reduced the incidence of strokes, but it did not produce the other events like myocardial infarction, heart failure, cardiovascular death, or death due to all-cause all-cause mortality. In case of kidney, how do you know how much should you lower? You see, sprint study is very unique because one criteria for enrollment, some of the patients was because they had to have one of those enrollment criteria was really low eGFR down up to 20. So 60 to 20 eGFR was the enrollment criterion. And similar thing, you get some information for MDRD study and follow-up of MDRD study, where also the blood pressure lowering. And it was shown that lowering in these people benefits only if the kidney patient has albuminuria. Those who have heavy albuminuria, they benefited, but everybody did not benefit. Similarly, you see the KDIGO study, KDIGO guidelines rather, there also they say that everybody does not benefit when there is a kidney disease. So progression of renal disease is not halted, but sometimes benefit only is mortality benefits is shown. Mortality benefit. Very good blood pressure there, where mortality will be reduced. So there is benefit in one or two important parameters. You see, and in case of strokes also, you like to lower it, obviously, but if there is a major vessel problem, you know the risk of lowering. No doctor, who knows his patient that they're very bad carotid artery disease and then lower the blood pressure very much. You know that you're not supposed to do that. So yeah, that is what is called individualization. Next slide. Next slide, please. Yes. So this is the sprint study and systolic blood pressure intervention trial, you see, and about 9,000 or so patients there, and intervention group was really systolic of 120, and in the other group, 120 to 140. This is the standard treatment. And of course, it was published in 15 and again back in recently in NEJM. Next slide. Okay, the trial population was 50 years or older and systolic blood pressure of 130, 180, and one of these additional conditions present: cardiovascular disease, kidney disease, pre-existing already, 10-year or greater 10-year risk of cardiovascular disease. On Framingham scale, will be 15% risk. So very high cardiovascular risk people, older people. So these were important criteria for enrollment. And these were the exclusion criteria, some very obvious one, and rare thing, but you would not enroll those people. So I'm not going to go into details of that. Next slide. Yes. Methodology, you see, of course, in the 1-to-1 ratio randomization and trial outcomes, you see, the primary outcome was a composite of myocardial infarction, acute coronary syndrome, you see, both not resulting into death, and stroke, and acute heart failure, decompensated heart failure, and death due to cardiovascular disease. And secondary, again, was a combination of all this, individually, any of these primary outcomes and all-cause mortality. These were the secondary outcome that was calculated in the study. Next slide. See, and yeah, and here you see the data. You realize that primary outcome and death from any cause and lower is the real one. But in order for you to see the difference, it has been enlarged here, and it has to be done. Otherwise, you won't realize that there is a clear difference, statistically significant difference, hazard ratio of 0.73. You see, so the tight control, intensive control helped these people for the primary cardiovascular events, you see, and very, very significantly. So this was the conclusion of this study. However, and of course, each individual point is shown here, intensive group versus the standard group, and you see everywhere the intensive group is better. And so they uniformly, on various endpoints, you see there is a benefit. And cumulative also there is a benefit. So there is some uniformity of data. It's not going totally haywire in different directions. Then you have to worry about how your data came about. Next slide. And I think you see, and this is observational post intervention period, where again they saw some minor changes in the outcomes. And tell you finally the differences, I'll tell you exactly. In the intensive group, you see the initial, when they reported it in 2015, you see the primary endpoint, you see the reduction was the incidence was 1.65, in the standard was 2.19%. So a difference of 0.53. And when they took it further, it became 0.63% difference, highly significant. See, so I think this study did draw our attention to the fact that we should control the blood pressure better and better. Of course, with all the exceptions, which I told you already in the beginning. So I think many studies have shown that tight control helps, and the volume of literature on that. And there is one we call is called the secondary prevention of small subcortical strokes. It's a very interesting study. Again, it didn't reach significance there, but there was reduction in the tight control group. There are huge meta-analysis of very good studies together. One meta-analysis with 16 studies together showing positive evidence that tight control helps. See, obviously, when you do this tight control, the side effects were high. Side effects in the tight control group were much higher, significantly higher, mind you. But fortunately, they did not ultimately affect the outcome. As a matter of fact, the outcomes were better. For example, there was acute kidney injury was little more in the intensive group. However, the recovery was up to 95%. See, or obviously there was bad hypotension episodes and hospitalizations, you see, but ultimate outcome were definitely good. So the side effects were there. So you have to grapple with those side effects, and probably it occurs very often. Obviously, you will again relax on your control. So that is what a doctor will do. But remember that if you can achieve it, it is worthwhile. It is worthwhile. See, very easy to achieve. There are all kinds of patients, as you will remember from your patient group. One who is controlled on 1 or 2 simple tablets. Your first line, like ARB and a little diuretic, is beautifully controlled. And then you get a reading of 120/80. You should not worry. You should not tell the patient is low. This is where you want to go. And you achieved it, and there's no side effect, no postural hypotension, no problem. I think you should continue that. This is the lesson to be learned. And I think next slide, if we can go over quickly, Doctor. Yes. Yeah. The hazard ratio, you see, now if you see all these different parameters, different groups, you find that the benefits are in all groups. That also shows the data is strong. The strength of data, the benefits are not in certain age group only, or in certain gender only, or certain population only, or certain initial blood pressure. So this is important. This gives strength to the data. Next slide. Next slide, please. Yeah. So I think this is what I told you, 2.1 versus that. So conclusion is, you see, yeah. So you can see here regarding each individual parameter, differences between the intensive group where there is a less incidence, and individually there's an acute coronary syndrome, stroke, and all that. So frankly, it is beneficial to control blood pressure tightly, provided you don't have any bad side effects. It's as simple as that. Individualize your treatment. But target is 120 by 80. Target is 120 by 80. You see that in elderly people, the diastolic pressure tends to be low. So if the diastolic pressure is less than 70, or your mean arterial pressure again is very low, then there is a possibility of poor coronary perfusion in these people with the less mean arterial pressure, and that can precipitate angina, can precipitate problem. So there are some caveats everywhere. That's why the practice of medicine is so complex, yet it is scientific and based upon some studies like this. I think this should be the last, next slide, Dr. Yeah, so I think the summary is obvious, and we will be again discussing, Dr. Sate, highlighting some of these points. So I'll call it off here and uh, hand it over back to the organizers. Thank you. Yeah, to Dr. Sanjana.
Thank you, sir, for the insightful talk. I request the audience to kindly pose their questions in the Q&A section. Dr. Chandalia, what's your opinion of the SPRINT trial and its influence to the Indian population?
I don't think Indians are very different, but like Dr. Sate also interact on that. I would apply it. We always look for differences, but many places we find that because the overall coronary artery disease is commoner in Asian population and Indians for sure. See, so always you feel that any differences we see, benefit is always more in our patients, like even glycemic control with all these ages, different ages. The Asians benefit more than the Caucasians. So I feel that we have to take the same course. We should really follow those and try to achieve as good control as possible.
Dr. Sati, your views on this?
Yeah, I would totally agree that Indians are no different. But I'll just give you a perspective of the SPRINT. If you see the data published in 2015 and 2021, the major difference, if you really find that all parameters were good, but except one which changed. The first SPRINT, there was no change in the incidence of strokes. So if you see the p-value, it is 0.48, and over a follow-up of 5 years, the stroke reduction was 0.09, the p-value. So the main difference was stroke reduction, and what that tells us is that BP control has to be perfected not over a short period of time. And that is extremely important, because when we start antihypertensive drugs on patients feel my BP is okay, they start dabbling with the therapy. And in fact, if you want stroke reduction, in fact, it is for a longer and persistent for a long time. This was the main change in the two, if you see the two publications from 2015 to 2021. And that's an important feature. And that is why for prevention of stroke, obviously cardiovascular events, but I'm telling you, as far as all the complications, perhaps stroke is the most disabling disease we can ever find. And we can prevent this if we really go low on the blood pressure control. And that is the problem with, say, doctors and patients at both ends. We find that this is taken very, very casually at both ends. And that's the important, what we have seen in the publications of 2015 and 2021. And as Professor Chandalia said, no difference in Indian patients. There should be no reason why our goals should not change, provided the complication rate, obviously the side effect profile we are going to see in all our patients.
Thank you, sir. Dr. Sati, we have a question. A patient 70 years of age with a long-standing MI and diabetes was COVID positive. Now his blood pressure cannot be controlled. It's around 190 by 120. The patient is on lisinopril, amlodipine, bisoprolol, metformin, and vildagliptin. What should the mode of treatment be, and what should the blood pressure goal be?
See, basically for elderly patients, if you see the targets, they moved from initially, 5 years ago, it was 150, 160 was okay. And now they have come back to 140. So we should still target 140 to 150 at this age. But yes, we should go on higher doses of, if you have resistant hypertension, if you start getting resistant hypertension, the first thing we have to see is the adherence of drugs, and optimal, the dosage should be optimal. In fact, I'm telling you, we did a hemodynamic study of periscope of all central aortic pressures and hemodynamics in almost 500 patients pre and post drugs. And we found that if the drug dosages were suboptimal, for example, the best drugs combination, which in this particular subset of hypertension was minimum 10 milligrams of amlodipine and 10 milligrams of ramipril, or 10 milligrams of amlodipine and 80 to 160 milligrams of telmisartan. So number one, the drug doses have to be optimal. That is number one. Number two, in elderly patients, where especially number two things we have to see is the actual central aortic pressure. So we would like to do a central hemodynamic study on a periscope to find out whether we are not dealing with pseudo hypertension. So we do a lot of I do a lot of internal hemodynamic studies which are from non-invasive methods, and we found in those patients where the vascular resistance, that means if the vascular age is very high, they tend to be actually really resistant. So that one more factor we have to see. Otherwise, there are two drugs, if not added, after adequate doses of amlodipine, ACE, ARBs, is spironolactone inhibitor, that is aldactone. That really helps, almost 50 milligrams, looking at the potassium. And the last drug which we have tried, there's a British paper for resistant hypertension where nothing could be controlled. We have a very small number of patients which I have done, but that was after the British report which came, that we give ARNI in these patients, and we have found, forget the LV function, and ARNI is perhaps the last step which can be tried in patients who have resistant hypertension after giving adequate doses of all drugs, including diuretics and aldactone. That is the last drug which you could use.
Thank you, sir. Dr. Chandalia, so in elderly hypertensives, we often see hyponatremia when going for vigorous control. So how do we avoid it?
Hyponatremia? Yeah. I think while giving diuretics, we have to be very careful. And what has come out winner in sprint study, what was used was thiazide, but chlorthalidone. Chlorthalidone in low doses, like I frequently use 6.25 milligram, even 12.5, I'm not bold enough to use frequently. And with that, I get away without any problems for hyponatremia. Hydrochlorothiazide, earlier when we used to use, we used to get into trouble. Bad hyponatremia and bad hypokalemia, very bad hypokalemia. So electrolyte disturbances were profound. And other way around, of course, you have to worry about hyperkalemia, especially when you use ARBs or ACE inhibitors, as well as, of course, the spironolactone. So these are some of the electrolytes that you have to watch when you are treating hypertension and the drugs that you use.
Thank you, sir. Dr. Sathe, should aggressive BP control be followed in 2 or more CVD risk factors?
Oh, yes. Overall, now we know that, our target should be minimum 130/80, but we should try to go between 120 to 130 now. Though the targets, the latest sprint, what has been published, is not going to come into guidelines so quickly, that going below 120. But yes, the higher the risk factors, we have to be more aggressive about BP control. And that's important because now I'll just give you the perspective of this 130/80. If you see the guidelines from Canadian guidelines, European and USA, they all changed except the Canadian guidelines. From day one till date, they said 130/80 should be the control. And why is this? Because they evaluated all the risk factors associated with the variation in so many patients. And now we have several papers on what is called blood pressure variability. And if your baseline blood pressure, if you're targeting 120/80, even if you get BP surges, it doesn't translate into cardiovascular or cerebrovascular events. And that is the reason why the higher the risk factors, we have to go lower on the blood pressure or be aggressive on that. The only problem with the sprint trial was they excluded diabetics. And that is, in fact, in our practice, diabetics, we are large chunk, majority of the patients have diabetes. So I would just like to ask Dr. Chandalia that though the sprint trial did not include diabetics, say diabetics without any CKD, what would he now keep the goal with this new sprint data?
I think I'll take them to the same goal for sure. I would say with our routine blood pressure measurement, as you said, I'll also target between 120 to 130 systolic and 80 diastolic, something like that. See, I would target that unless there was some clear contraindication. I think we should target that. See,
Okay.
yeah, even in diabetic, we may be even better, even a bit stricter, if possible, very close to 125, or with our routine methods. The office reading taken a little better way with better technique. See.
Thank you, sir. So in the Indian scenario, should aggressive control be followed in all age groups? Dr. Chandalia?
I think except very elderly, which I alluded to in one Japanese study, that Japanese meta-analysis, and elsewhere of experience of all the many doctors who treat large number, elderly people, you'd like to be careful because the mean arterial pressure also will go very low. Their diastolic is not very high. And the elderly people often have a very bad systolic hypertension. And you start lowering that, diastolic is already 60, 65. And that goes further down. The mean arterial pressure goes very low. And of course, the coronary perfusion is affected. And of course, may have cerebrovascular disease, carotid, vertebrobasilar system everywhere. You see diffuse atherosclerosis everywhere. So I think I would be careful in elderly people. I would still say 135, 140, I would permit systolic, especially if diastolic is also low. See, I would not like to lower it too much.
Yes, I would entirely agree because in the elderly, there is a J curve for the diastolic pressure. So once you go down less than 70, you start getting, in fact, the risk increases. And there are three subsets where you have to be careful in this subset of patients. Number one, patients with known coronary artery disease. Number two, patients with LVH, left ventricular hypertrophy on echo, or LVH with strain on ECG. If you have these three subsets in an elderly population, you have to be extremely careful of going low, below 70 as the diastolic pressure, as Professor told us.
Thank you, sir. So in this pandemic, will it be possible to maintain and intensify the blood pressure control? Dr. Sati?
See, basically, it's not a question of pandemic. In general, we must sort of be the awareness of keeping targets should be irrespective of what is happening whenever it happens. It doesn't really matter, actually. The problem is post-COVID, I must tell you, in the pandemic, post-COVID, there was a lot of BP variability, which has come, and we have seen this now routinely in the last 1 year. People get hypertensive episodes. A lot of people get hypertensive episodes. A lot of patients who were non-hypertensive became hypertensive. So pandemic actually gave us a lot of BP and heart rate variability. That is the only change we have seen in this pandemic, during this pandemic era, clinically, I'm telling you. But as far as the goals are concerned, I think there is no reason why there should be any change in the goals and the clinical subsets we see.
Dr. Chandalia, your views on this?
Yeah, I think perfectly agree. We always try to do the best in all those situations. You see, unless there is some overriding reason, like person is dehydrated, or blood pressure is less, or otherwise very sick person. So then, of course, you take a little different view because some of them can be very sick. So things can be different. But apart from that, I think whatever is true in non-COVID situation is true here.
Thank you, sir. So in reference to the sprint trial, which guidelines should we follow for targets? Dr. Sati?
See, basically, with the sprint trial, I would still say that minimum we have to target is 138. Now, why I'm saying this is, of course, with this new data, I would like to think of going below 120. The problem is, even the target of 130/80 is achieved in less than 10%. See, that is why, we keep on talking of this theory and application of all these trials. But in practice, I would be, more aggressive in at least being aware myself, all my patients and all the medical fraternity in general, that let us at least be at 130/80. Let us start there and then individualize the patient. And then if you think the high risk factors are there, diabetes, that we might think of going low as far as there are no side effects. But let us start with what is the data currently, ESH, ISH and ACC. So target 130/80, go low with this new data, depending upon, and then you individualize the patient. But at least aim and please target 130/80.
Dr. Chandalia, your views on this?
Yes, I think I fully agree. I think we should aim high always. You can't achieve is different, but to set your aims at a low, at a level that's very easy to achieve, then I think you haven't taken the challenges. So you take the challenges and try to go there.
Thank you, sir. I don't think we have any more questions coming in. So some closing comments, Dr. Sati.
Yeah, I would just like to sort of tell all our fraternity that as far as hypertension is concerned, it's not good enough now in our OPD. What we used to do, OPD of 50, 100 people coming in, just taking BP, everything is okay, chalta hai. That attitude is no longer true. We have to go beyond this. In fact, in our OPD, we are doing what is called a hypertensive profile in the patient, which we may talk later. We have periscopes, we do so many 24-hour BP monitorings that we'll see later someday. But in general, the casual approach of a patient coming in and saying that, okay, your BP is 150/90, it's okay, you're asymptomatic, that's not on. So those days are gone. All these trials which have come up, we must be aggressive in targeting going to the targets and increase the doses. I am telling you, India in general is known for homeopathic doses of all drugs. Diltiazem half TDS, even telmisartan half twice a day. Whatever you use, it doesn't matter really. In fact, there was an article in BMJ many years ago which said that if you go to the targets, what you use is irrelevant. So please use whichever drug you want, but come to the target, and we must be aggressive in this so that we can prevent cardiovascular and especially cerebrovascular complications of hypertension.
Dr. Chandalia, any closing comments?
Yeah, I think I fully agree with what Dr. Sati said. I think we are using inadequate doses. But also one approach which was always taught to us some 30, 40 years ago, that use multiple drugs as well. So in case you have difficulty by exhibiting full dose of a drug, try to add another group, of course, which the 2-3 primary groups like ASB, ARB or ACE inhibitor, number 1 diuretic, and calcium channel blocker. So I think you also employ multiple types of drugs as well, and of course give them in adequate doses until you reach your target, without, of course, producing any disaster. Because once you do that, bad hypotensive episode and all, patients don't take it very kindly, frankly. I don't know whether they will after that comply with you. A bad episode lands them in the hospital. You see, so we all insist now that patients monitor their blood pressure, all of them, and those instruments, automated ones, are now become better and certified and they calibrated. So I think, and they're supposed to send you readings on email. We monitor blood sugar, pressure both, and we check it on email initially for for 2 to 4 weeks every time we give new drugs, and then only you can push to your targets safely. Yeah.
Thank you so much, sir. Thank you, Dr. Chandalia and Dr. Sati. I now request Mr. Parameshrava, sir, to give the vote of thanks.
Yeah. Thank you, Dr. Sanjana. And on behalf of Microlab Carcian 3, I really thank Dr. Hemraj B. Chandalia. Even at his age and a bubbling energy, whenever it comes to academic, I always seen him, he's having so much of energy. God only knows how he gets it, this much energy. A really wonderful talk, sir. I really thank for your valuable time, giving such a wonderful talk on newer perspective in hypertension management. And also, I thank Dr. Sunil Sate, giving his valuable time from his busy schedule also. So both are so busy, and I really thank that the two on Sunday, they have taken out such a valuable time and given us such a talk and their perspective regarding hypertension management. and particularly now in this after this COVID, there is a lot of webinars are every day. Today, even there, I heard even in Mumbai itself, there are about 4 parallel meetings are going on. Even then, I have seen about more than nearly 700 logins are there. I am very happy that all the delegates, those who have taken out their valuable time to hear this eminent both speakers, Dr. Sunil Sathe and Dr. Chandalia. And I really thank each and everyone giving their valuable time. And I look forward to do many more programs like that. And I definitely value all your valuable time. And thanks once again. Thanks from Carcian 3 Microlabs.
Thank you. Bye-bye.
Thank you, sir.
Thank you,
Bye-bye,
Microlab.
Sunil.
Thank you,
Bye-bye,
Dr. Sathe.
Bye-bye,
Lovely
Sunil.
sharing the platform with you.